Pediatric Splinting by Kaylee Severance and Jessica Miller. Occupational therapy practitioners traditionally use the term splint to describe temporary devices fabricated to support a part of the body, whereas the term orthotic was used to refer to a more permanent device. The purpose of an orthosis or splint is to protect, correct, or assist a joint, limb, or muscle to increase functional performance. For example, an orthosis might protect an injured wrist from increased pain when a child or adolescent is playing, or prevent deformity occurring during sleep. An orthosis might help support a child's wrist to make writing more efficient. Common types of orthoses. Elbow orthosis. Stabilizes and may limit motion of the elbow. Shoulder orthosis. Statically stabilizes or limits motion of the shoulder. Shoulder, elbow, wrist, hand, finger orthosis. Protects medical conditions of the shoulder, elbow, wrist, hand, and fingers during the healing process and/or reduces contractures. Finger orthosis. Protects medical conditions of the finger and thumb during healing process and/or reduces contractures and stiffness. Hand-finger orthosis. Protects medical conditions of the hand, finger, or thumb during the healing process and/or reduces contractures and stiffness. Orthoses that improve hand function. Serial static orthoses. Immobilize the joints in a stationary position. The serial static orthoses applies continued force to maximize the length of the tissue and is worn for long periods of time, allowing the tissue to adapt. Once the tissue has accommodated to the stretch, a new orthoses may be made, or the old orthosis is remolded to hold the tissue at a new maximum length. Dynamic orthoses apply force to one or more joints. These orthoses include a rubber band, pulley, spring, screw, hook, elastic, or other out-triggers to provide continuous force. These types of orthoses are not worn as long as the serial orthoses. The force is continuous while the orthosis remains on, but the orthosis is removed periodically. Static progressive orthoses are used to apply adjustable static force. The orthosis is applied at the joint and is positioned at its maximum. The force is then adjusted when the tissue response allows repositioning to a new length. Examples of splints. Design considerations. Orthoses may stabilize, support, or protect body parts, enabling children to use their hands during activities of daily living, education, play, and social participation. Practitioners consider many factors before designing and fabricating an orthosis to help a child engage in daily occupations. The practitioners consider the child's age, diagnoses, motivations, interests, habits, and routines, along with the context in which the orthosis will be worn. The occupational therapy practitioner also considers the child's physical abilities, muscle tone, strength, endurance, and structure. The occupational therapy practitioner uses clinical reasoning to determine the best solution for the child. General principles of orthoses. Externally stability may improve mobility and allow clients to engage in occupations. Orthoses provide continuous stretch to a muscle. Orthoses position client in a functional position. Orthoses should improve or maintain function. Orthoses should allow clients to participate in developmentally appropriate activities. Common diagnoses utilizing splinting interventions. Cerebral palsy. Functional orthoses that facilitate proper positions of arms. Quadriplegia. Wrist or hand immobilization orthoses. Antispasticity, neoprene orthoses, or wrist and finger orthoses. DMD. Functional orthoses that promote stability in weak joints for increased function. Juvenile rheumatoid arthritis. Functional orthoses fabricated to promote range of motion for engagement in functional activities and for protection and to decrease deformities. Compliance. The motivation to wear an orthosis depends on how well the occupational therapist has addressed the client's concerns. Generally, children and adolescents will wear an orthosis that helps them do the things they want to do. Educate the client and his or her caregiver regarding the purpose and goal of the orthosis. The client may be more apt to wear the orthosis if he or she understands why it is necessary. Provide simple, written, verbal, and pictorial instructions. Use positive reinforcement, like verbal praise or stickers, for following the orthosis schedule. Design the orthosis that are attractive and pleasing to clients. Demonstrate the proper orthosis application to a client and his or her caregiver. Label the orthosis clearly. Color coding or using a number system to show the client and caregivers how to don or doff them will improve and be helpful. Fabrication. The OT and the OTA often assist each other during the fabrication of pediatric orthoses because of the special issues of this population. OTs may modify a pattern, design a pattern unique to the client, or use a prefabricated pattern. OTs must ensure that the orthosis fits properly and achieves the desired outcome. The material should not cause any irritation or rubbing. The straps keeping the orthosis in place should be long enough to hold the orthosis in place, but not so long to cause extra material to be left hanging. All edges should be rounded to make sure that they do not rub against the client and create pressure sores. Materials. Aquaplast has 100% memory and is recommended for large, serial, and orthoses for spasticity. Easy Form has maximum resistance to stretch and is extremely rigid, and it's recommended for patients who are unable to cooperate. Fabric Form is an extremely thin material and great for lightweight orthoses, and it's recommended for finger orthoses. Flex Form is easy to mold and is recommended for elbow orthoses. Orthoplast has excellent durability and is recommended for static or functional positioning along with antispasticity orthoses. Orthoplast 2 drapes well for a close fit and is ideal for static or dynamic orthoses along with finger orthoses. Increasing compliance. After fabricating a splint, ask yourself this: does it address the desired outcome? Is it comfortable to wear? Is it easy for the child or parent to don and doff? Will it transition into the child's routines well? And does the child like it? Remember, provide instruction and demonstration, use positive reinforcement, and involve the family and staff, and make it fun. Kinesio taping. The Kinesio-Tex tape is a type of tape that can be used as an adjunct to therapy. The Kinesio tape can be applied to protect weakened limbs and is also used as a conservative treatment or alternative treatment to surgery. The primary goal of taping as an adjunct to intervention is to aid the body in self-healing. Taping provides the stability that is needed to move effectively. Kinesiotaping addresses the following areas: muscular functions, joint functions, lymphatic functions, and skin functions. For more information on splinting, refer to the Pediatric Skills for Occupational Therapy Assistants, written by Jean W. Solomon and Jane Clifford O'Brien, and the following websites for info on materials and tips. This concludes our presentation on pediatric splinting.